participate to the Vietnamese Society of Radiology meeting, and thank you to Professor Phan Minh Tong and Professor Vu Dong Lu for the very kind invitation. So I will now discuss revisiting intracranial aneurysm treatment, what's new regarding coiling and flow diversion. So my topics are, I will discuss coiling, I will present you optimal coils, and I will show you the preliminary results of instant study. I will also show you flow diversion and what we can do with the Silk Vista and Silk Vista baby flow diverter from BALT. And I will show you some clinical experience we have with this flow diverter. So coiling, optimal coils, instant study. So what is the current place of coiling in the aneurysm treatment? So I show you here the results of ARETA study conducted in France regarding the modalities of endovascular treatment according to aneurysm status. You see that for ruptured aneurysm, coiling alone or balloon-assisted coiling was used for ruptured aneurysm in 98% of cases, which is not a surprise. For a ruptured aneurysm, the rate was lower because we are also using a web flow diverter on stent-assisted coiling, but you see that the coiling is still 73% of cases for a ruptured aneurysm, and in global, the rate of coiling is 88% of aneurysm. So coiling is still the first-line treatment for intracranial aneurysm. So what is the Optima coil system from BALT? The Optima, it's an optimal design with a novel hypotube pusher offering best-in-class distal softness for precise deliverability and control. And really, in our department is our first-line coil, and let's say that we exclusively or mostly use this coil, and it's a very good coil. So detachment is in an instant with thermal detachment. It means that you press the button and the coil is detached. Implant with optimized softness profile and increase size offering, which is good. You have a lot of sizes, so you can really select your coil for the treatment of intracranial aneurysm. I show you some example here. Ruptured decom, you see the bleeding here, you see the aneurysm here, you see the placement of the coil, you see the aneurysm here, you see the placement of the coil in the aneurysm, 5 optimal coils. It is a final control angiogram, and it is a 12 months control angiogram showing complete aneurysm occlusion. Here, another example, ruptured MCA treated by clipping. You see the clipping, the clip is here, and the surgical way is here. So you see that we have a control angiogram after the treatment, and we have an aneurysm remnant. So we were deciding to treat this remnant with coils. So we were using at the beginning a non-optimal coil, a coil from another company, and it was not possible to place the coil in the aneurysm sac. You know precisely that it's difficult to treat a clipped aneurysm because the clip is very rigid, and the coil is pushed outside the aneurysm sac. So we were using an optimal coil. We were able to place an optimal coil, and it's a final result showing complete aneurysm occlusion, and it's a 12 months control angiogram showing complete aneurysm occlusion. Instant study, what is it? I am the PI, the sponsor is BALT indeed. The device used in this study is the Optima coil system. The study design is a non-interventional prospective single-arm international multi-center study. The sample size is 300 patients, and it was conducted in 7 countries with 19 centers active in Europe. The objective was to evaluate the morbidity and mortality global, indeed, related to the optimal coil system at 30 days and 12 months post-procedure, to evaluate also the occlusion rate at 12 months, and to evaluate some technical features, specifically for the detachment system of the optimal coils. There are some committees. The core lab, there is an independent core lab who is Professor Phil White from Edinburgh in UK, and there is a clinical event committee with Professor Denis Abreteau in Tours, France, and Dr. Anne-Christine Janelle in Toulouse, France. So we have conducted an interim analysis. So recruitment is completed, but not all follow-up are available. So we were conducting an interim analysis with 150 patients having completed the 12 months follow-up. We were evaluating safety and efficacy according to the investigator assessment. So it is a flow chart. I have no time to discuss the flow chart. The population is, the mean age is 55. As usual, more females than male. You see that the rate of hypertension, elevated blood pressure is 40%. Smoking active is encountered in 38% of cases. Most aneurysms were unruptured, 55% of cases, and 44 were ruptured. Most aneurysms were small, at 92%, and location were ECOM first, 44% of cases, ICA supraclinoid, 30% of cases, MCA, 16% of cases, vertebral basilar aneurysm, 6%, and finally, ICA intracavernous, 3%. So, when we look at mortality at 30 days, you see that there was no mortality, 0% mortality. There was morbidity in 11%, but it was related to subarachnoid hemorrhage in most cases, 10%. It was related to procedure rebleeding during preoperative DSA. It means before placement of coils in 0.7% of cases, and related to another disease, lung cancer, in 0.7% of cases. So indeed, morbidity was mostly encountered in ruptured aneurysm, 24% of cases, mostly due to subarachnoid hemorrhage. And in unruptured aneurysm, you see that the morbidity is very low, 1.2%. Now, when we look at anatomical results, postoperatively in unruptured aneurysm, you have complete occlusion in 78% of cases, and in ruptured aneurysm in 87% of cases. At 12 months, we have complete occlusion in 79% of cases, and in unruptured aneurysm, and in 60% of cases in ruptured aneurysm. Don't forget that it is self-evaluation of the centers and not core lab evaluation. So we will check in the future indeed the results of the core lab evaluation. Flow diversion, Silk Vista. So what are the current indications for flow diversion? Due to its high efficacy, flow diversion is increasingly used in the endovascular treatment management of intracranial aneurysm. Initial indication in Europe were large and giant ICA aneurysm and recanalized aneurysm. With the development of new flow diverters, singularly the Silk Vista, we have a progressive enlargement of indication to small ICA aneurysm, distal aneurysm, bifurcation aneurysm. The use of FD remains controversial in the treatment of aneurysm located in the posterior circulation, and to some extent, the use of flow diversion in bifurcation is also still a little bit controversial, but I have to say that we use a lot of flow diverter in bifurcation aneurysm. So, an overview of the Silk development. The Silk was introduced in 2008. In 2012, we had the Silk Plus. In 2018, we had the Silk Vista Baby. And in 2020, the Silk Vista. So there was a diversion study. So there was an analysis of the result of silk treatment in diversion study, which is a last study conducted in France, analyzing all flow diversion treatments, whatever the flow diverters used. So we were conducting a silk subgroup analysis was conducted. You see that the treatment took place between October 2012 and February 2014. There were a little bit more than 100 patients. You see that mortality was 2.9%, morbidity 26.5%, and aneurysm occlusion was complete aneurysm occlusion at 1 year in 64% of cases, and adequate occlusion in 82% of cases. Silk Vista and Silk Vista Baby, you see that it's 48 braided wires mesh-like design. Silk Vista and Silk Vista Baby are made of DFT wires, so 19 with platinum inside, which give full visibility of the flow diverter, as you see here. It has a homogeneous mesh surface, which make the stent opening very smooth, and it has radial resistive force, which make an increasing compression stent force, with which lead to good wall apposition. And finally, we have the high stent conformability, which make it very navigable. You see that here it is very conformable to a very tortuous vessel. Silk Vista Baby, we have several diameter, 2.25, 2.5, 2.75, 3, 3.25. It is the first and only flow diverter deliverable through the 17 microcatheter. The Silk Vistas 3.5, 3.65, 4, 4.25, 4.5, 4.75, and it is deliverable through the 21 microcatheter. Just to show you some example, here an aneurysm, IC aneurysm, posterior communicating aneurysm. The strategy was decided to be flow diversion and coiling. So we were placing coil, but we were not able to deploy a flow diverter, which was not at the time of this treatment silk. So we were just placing coils, and we were coming back in October 2021 with this recanalization, and now we were able to place a Silk Vista 4.75 by 20, and it is the end of the procedure, and you see that the stent is perfectly open and perfectly applied against the arterial wall. Here another example, unruptured ECOM. You see that the width is 11, the height is 8.9, it's a relatively large aneurysm. We treat the aneurysm with a Silk Vista Baby 2.75 by 10. And you see here, we have also a microcatheter in the aneurysm sac to place coils. You see it's a vasosity after deployment of the web. And after that, we will place some coils on the final control angiogram is complete aneurysm occlusion. Here another example, MC aneurysm with a very wide neck. You see that one branch is more or less coming from the neck, this one. So what we do here, we will place a flow diverter here. So we use a Silk plus 3 by 15, and it is the final result. You see that the postoperative DSA show a good placement of the stent without any stenosis in the stent, and it's a 6-month DSA showing complete aneurysm occlusion. Here, it's a superior cerebellar aneurysm with a wide neck treated with coils in March 2015, recanalization in May 2016, treated with web, recanalization in January 2021, treated with a Silk Vista Baby 3.25 by 15, placed in the left P1 and basilar artery. You see the Silk Vista Baby here, and it's a final control angiogram, and it's a control angiogram 6 months later, showing complete aneurysm occlusion. Here another example, ACOM aneurysm treated with coils in 2015, RECAN in 2021, treatment with a Sigvista baby 2.25 by 15 with on coils, and it is a final control angiogram showing a very good opening of the flow diverter with good apposition on the arterial wall of the complete aneurysm occlusion, and DSA at 6 months show a complete aneurysm occlusion. Here, another example, ruptured MCA treated in January 2012 by clipping, and it's in March 2022, we see that we have a recanalization. The treatment is decided for endovascular treatment. So what we do, we place the flow diverter. Again, you see that we are able to precisely place the flow diverter in front of the neck. The flow diverter is completely visible, the vasosity, and it is, we place optimal coils in the aneurysm remnant, and it is the final control angiogram with complete aneurysm occlusion. In conclusion, optimal coils has a very good instantaneous detachment. They are associated with a great safety. Sigvista and Sigvista baby are fully visible. They are delivered through the small microcatheters, 17 for Vista baby and 21 for Vista, permit enlargement of indication to distal and bifurcation aneurysm. Thank you for your attention.
Next topic, cerebral artery occlusion treatment update. I hope to get a lot of information this lecture. Professor Laurent Pierot from Vietnamese, please.
Hello, it's a real pleasure for me to attend the meeting and to be part of the meeting and to report on our experience in the treatment of acute ischemic stroke. So which device to use, which technique is a debate that is going on for a long time, and concerning the devices themselves, it seems that one efficient way to differentiate among the efficiency is to check the first pass rate. Obviously, the ability within one pass to completely reopen in order to obtain a TK3 without the need to do another maneuver, to take another aspiration, to take another stent retriever, is an important prognostic factor. And this allows to compare the different devices amongst themselves. This is the first publication about this topic that was initially done by Osama Zaidat, where he checked on the results in a stroke registry in the US, and found out that when using a balloon guiding catheter, the efficiency, the first pass effect obtained with the solitaire was of 25%. And he looked at also for other devices when handling the Trevo, the first pass effect was of 23%, which fits also with our experience. In our experience, we've been using the different devices and we obtained the best results when solitaire is being used. However, there might be some important points to consider, how to position the stent retriever, which may be a bias, probably more in inexperienced operators. Look at this situation here. This is basilar bifurcation with thrombus obviously occluding the right superior cerebellar and potentially the right posterior cerebral artery. Indeed, there was no PCOM here, so the clot was occluding both arteries. The operator who did this procedure placed the stent retriever in the left PCA, which is not the artery to recanalize. So in this situation, there's a wrong placement of the stent retriever in the artery which is not occluded, and the fact that this does not enable it to reopen the right PCA is not really surprising. So failure of first pass, should it be counted here? I'm not sure. Second pass, indeed, the correct artery was accessed, but look at the length of the solitaire. This is the end of the solitaire. Here's the proximal part. Obviously, the device has been placed very much too proximally. It should have been placed more distally. So again, I'm not surprised that it was a second failure. And indeed, only the third pass, the device was placed in the proper artery, in the proper position, and this enabled it to reopen. So this patient is not quoted as first pass effect, but probably as a problem is more related to the technique used rather than the stent retriever itself. So thrombectomy, there are a lot of discussions and studies going on whether it should be done for low aspect, low NIH. And here is, for instance, one patient where you may have concerns whether it should be treated. He came in acutely with acute diplopia, nothing else. And usually, if I see a patient with acute diplopia, we think of an aneurysm of the posterior communicating arteries that just developed, that compresses the oculomotor nerves. But he did have any aneurysm. And if you check at the arteries, the PCA is coming from the arterial circulation. It seems all more or less fine. However, this is a bit strange. Is this an aneurysm? Or what could it be? Here are the reconstructions of the CT angio, and definitely there is not an aneurysm of the basilar tip. It's a P1 segment, which is distally occluded, and then we diagnosed here a focal occlusion at the P1 segment, where it may be debated whether this patient should be treated or not, but diplopia is very invalidating. And indeed, you see here also that the PCOM is a bit smaller than the PCA. So definitely this PCOM is not being used usually. We placed the stent retriever, retrieved thrombus here, which is not there anymore. And look at the lateral view here of this perforator that reappeared and that was not visible before. This patient had almost no symptoms, but definitely it was a good thing that treatment could be done. One of the other debates that are going on is whether what treatment and which way to proceed if the usual technique fails. And here are examples of procedures that are done with failure, and not only with failure, but these are procedures in the night. And you see that the more we go on, the less enthusiasm there is. Here is the occluded ICA at 11:15. This is the first pass that failed. 10 minutes later, then a second pass that failed again, then a third pass that failed, the fourth pass, you see time is running, fifth pass failure, sixth pass. What to do? Should you continue? At some point, we lose enthusiasm and we lose also hope that we'll be able to reopen. But there's worse than failure. Says failure and upgrade and complication. And here is this patient with a superior MCA, which is occluded. And again, this is before first pass. And you see that sometimes later, not only that we failed to reopen, but unfortunately the M1 segment got occluded too. Unfortunately, as soon as you do procedures, we know that failure and complications are unavoidable, and that there's large variability in the recognition rates. Even if all studies only show very good results, we still have situations where we fail, where it does not work, and somehow this may be related to the level and experience of operator, but also to the differences in devices and techniques. So which techniques to be used? The debate is going on between distal aspiration and centrifuge. In our practice, we never aspirate. We only use centrifugers in combination with the balloon guiding. And there's an important trend to use a combination of centrifuge and aspiration, with different opinions stating that if one of the technique does not work, combination of these techniques enable to reopen vessels. And indeed, I can show example of this, various examples of LVOs. Here is a distal M1 occlusion where first pass, second pass, and third pass mostly failed with a conventional centrifuge, whereas a combination between aspiration and centrifuge enabled to reopen the arteries. But still, in our practice, this efficiency remains quite low. And if we have to combine techniques, we prefer to combine centrifuges rather than centrifuge and aspiration. And this works, in our experience, a lot. So we move from centrifuge to double centrifuge, where this is something that we do very frequently. And here, another example, distal M1 occlusion. We try to place each centrifuge in a different branch. This is a superior division, inferior division branch, 2 solitaires that are pulled simultaneously with a combination of the balloon guiding. And you see that they are coming together. We take extremely pay attention that we don't move first one and second the other one, in order to avoid pushing the clot from one branch to the other. And you see that if retrieval is done this way, then the ability to reopen is high. And in our practice, the moment when we do this procedure of using 2 centrifuges has been evaluating with time. Some 10 years ago, we only dared to do so after 4 or 5 maneuvers. And then we've been bringing it down to 4, then to 3, then to 2, meaning 2 single passes with a solitaire failure, double solitaires. But since 2 years, all strokes that we treat for carotid T and M1 are done primarily with the use of a double centrifuge. And the rationale, the reason to do so, is that the efficiency is extremely high. And here's an example, again, M1 occlusion, but directly we take 2 systems that we place ideally into both MCA division branches. Here is a simultaneous retraction, and because of both centrifuges, we see that the balloon guiding is very often pulled up, which increases a lot the aspiration. This is here 8 French balloon guiding, where in this position the efficiency is much higher than in the proximal ICA, and centrifuges are taken back. And to have a complete reopening, Marta from our team just checked the results in nearly 200 primary double solitaires, where the first pass effect is close to 60%. So combination of devices is usually for carotid T and M1, but we have some situation of distal Well, we try a single stent retriever, and after trying it several times, if it still fails, then you may see here's a plot. Here's one superior, one inferior division branch, and after failure of the usual technique, we finally put a small device inside superior and inferior division branch, and this enables to reopen it completely. You see all branches that were missing because of this. So what to do in case of still persisting occlusion after double stent retriever? There have been some attempts to bring a specific stent retriever for white clots, and indeed in some situations it has worked. I think the most common way to proceed is still to go on for stent PTA. And here are some examples. We all know those patients where we have an occluded MCA, where we go on with one or different stent retrievers, where we reopen, but it looks good. But if we wait, we progressively lose the artery again. So we may redo a procedure, but even if you redo as it was done and reopened, you see that after some time of waiting, the vessels reocclude. Definitely there is a focal lesion. We need to do something else. And here we did another attempt, but we did not leave it like this. And then we add a PTA followed by stenting in combination to integralin, to anti-GP2B3A. So should we do it? Is it correct to do so or not? There is a growing literature that shows the interest in doing so. First, there was this paper from Korea with 46 patients having acute stroke due to a decompensated stenosis. Some were treated by PTA alone, some by PTA and stent. And the number of recanalization was very high. And you see in patients where recanalization was achieved, the clinical outcome was significantly better than in patients where there was no recanalization. So definitely patients with an underlying stenosis, it's better the outcome is better if the stenosis can be reopened. The goal is to reopen the vessels. Keeping the vessels occluded is not an issue. But what about persisting occlusion, even if the occlusion is not due to a thrombus, not to a stenosis, but if the occlusion is due to a thrombus? And sometimes it may be difficult to differentiate thrombus and stenosis. Look here, this really looks like a stenosis, but after placing one solitaire, you see that it was completely reopened. However, we have now studies evaluating placements of stent after PTA in failures of thrombectomies. Here is a study here. We're using the EMBO trap, 200 thrombectomies, 26 failures. And from those 26 failures, about one half were left untreated, one half had a rescue stenting. So the outcome between both groups was very different. The outcome was here either 21% in the non-recanalized or versus 66% of good clinical outcome. This is a lot. So definitely it's much better to be able to reopen, which is possible with a stent. Other study, again, Korea, 208 thrombectomies, 45 failures. Those 45 failures were either left untreated, 28, or rescue stenting, 17. And the difference between both groups is again very important. Vessel left occluded, 7% of good clinical outcome. Vessel reopened with stent, 35% of good outcome. And again, a very high difference.